So you recording on my computer,
Okay, I've
right?
checked that. Yeah, it's recording now.
Yeah. Okay, fine. You can start now. Thanks.
Okay. So, good evening, everyone. I'm Dr. Etubi Ibrahim. Sorry, even the last time I know we didn't kind of introduce, but we're 10 minutes behind schedule. So I think we'll just start straight away. The last time we talked about control strategies, prevention strategies and all up until um, um, control and through the methods through which we could do the control, talking about controlling at the source, controlling at the root through the route of transmission, and then controlling at the level of the susceptible host. So I believe today we'll be starting from surveillance. Sorry, I didn't make the note from the beginning. I just started from where we stopped the last time. Maybe when I'm able to add all those other things, then I'll send it to us complete. Okay, so surveillance. Surveillance is a continuous scrutiny of all aspects of disease occurrence and spread, and the timely notification to relevant authorities. It literally means to watch over with great attention, authority, and often with suspicion because you are looking out for, you know. So it is an ongoing systematic collection, analysis, and interpretation of health data, but it doesn't just end with collecting, what you have noticed is that there's collection, then it has to be analyzed, then it has to be interpreted. But aside this, apart from the interpretation, when it is interpreted, it has to be disseminated to those who would need the information in order to take action. And that is very important. Surveillance is not complete by just taking the data, doing the analysis. It doesn't just end there. If it doesn't get to the one who needs to take action on the information, then it is not yet complete. So surveillance is essential both for planning, for implementation, and for evaluation of any public health program. So you would look out, it would, when you look out for, for things like, it could be diseases, it could be other health related events that you're, doing surveillance on, then you analyze, interpret it, and then you disseminate to the relevant authorities. I know a common example in our setting are the things we do in the hospital. We get certain data, we send to no matter how high you are, whether the primary health care centers, the secondary health facilities, or even the tertiary health facilities, they generate some form of data which goes to the area council of the respective local government areas, and from there to the state level, and then from there to the federal level. This communication can move both ways. It can be the other way around, maybe communicating down a program from the federal to the state brings it down to the local government, and then um, to the facility. So, but then depending on whether it's an emergency situation or not, there might be this communication might be more rapid the way it gets from one place to the other, or you know and then gets, at last it gets to more like a global level where it gets to the WHO. So data collected at the facility level is compiled and sent to the next level, and then regular feedback is shared with the lower level. Sorry, I don't have a diagram, but just I'll try and put it on the next one. It just means that there's a forward and backward kind of communication flow between the three levels, from the facility, the levels from the facilities or wherever it is coming from, which could be primary, secondary, or a tertiary facility, to the local government. Maybe if it's a disease of concern or some kind of notification, it could be through the DSNO, then from there to the state, then to the federal government. A standard case definition is used to identify such priority diseases or events, and the laboratory is recognized as an important component of public health surveillance. Maybe when we go into disease notification and epidemic investigation, it's where we'll talk more, because it's going to be a lot if we say we are going to dwell too much on this. But basically, when there is an event, let's say a disease or so, there's usually a standard case definition. For example, in the case of yellow fever, there's a standard case definition. In the case of measles, there's a standard case definition that helps us to recognize, or even in polio. So take for example, for polio, there'll be sudden, that is the case definition that is used that for flaccid paralysis, acute flaccid AFP, sorry, acute flaccid paralysis. So any sudden onset of paralysis, in that case, you begin to suspect polio, and in that case, you'd note that kind of case, and then notify it moved from the facility to the DSNO, who passes it onwards. Or in the case of measles, you talk of rash and fever. So there's actually, I'm not taking the complete statement now, but there are actually key definitions that points to a particular disease or event that should be notified or should be recognized. And then the laboratory is very, very important. Let's say for any disease that is picked, would need to, one, to actually, you want to rule out other possibilities. And apart from ruling out other possible differentials, you would also want to, there'll also be a way to identify that particular disease. For most of these viral diseases, we do PCR or something of the sort, and so we're able to like pick it out to actually have a confirmed case. So there are different kinds of case definition, which I won't bore us with that. But then for the case definition, usually for an operational case definition in the case of epidemics or diseases, we would have, say, there will be things like a suspected case, a probable case, and a confirmed case. And each of these ones will have their case definitions. So I'll try to input an example of that just to make it clearer.
Doctor, please, can you go again with the suspected, probable?
Okay, I said for different kind of diseases, when there are different kind of case definitions, but for epidemic investigation, what we commonly use is the operational case definition. That is basically what you are going to be working with. In our clinics, we could have clinical case definitions, we could have prognostic case definitions and all that. But when you are investigating or doing surveillance, majorly what we use is the operational case definition. And for those case definitions, you could have there'll be a suspected case, a probable case, or a confirmed case. Let me see if I can just pick an example for us to kind of take a look at here. Okay. 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 So while that is coming up, let me just quickly run us through it. Okay, sorry, I'll look for an example and get to us later. Let's just continue. Okay. So basically, they just have it in mind, like in the case of COVID now, there are suspected cases, there are probable cases, and then there are confirmed cases. Okay, the confirmed cases using the laboratory test. When you carry out your investigation and it turns out positive, That is a confirmed case. So a probable case could be maybe somebody who take, for example, he had contact with somebody who had symptoms that could be suspicious of COVID, or somebody who was even a confirmed case of COVID, but then you didn't get to even test this person and this person passed on. That could be a probable case because you're not able to carry out the investigation, but this person had a contact with somebody with the disease or probably because of the probable symptoms of the disease, and this person developed symptoms that looked like symptoms of COVID, but you were not able to carry out an investigation to prove that this was actually COVID. So this could be a probable case. And a suspected case could be somebody who just had the contact or something with the a confirmed case of COVID or even another probable case. You understand? So, but what I'll do is that I'll look for a typical example and show to us even as we continue. I don't know if you can still hear me.
Yes, doctor, we can.
Okay. Okay. Then types of surveillance methods. Surveillance systems. Usually for any of the surveillance we do, whether the one we do routinely or the other thing, that could be classified basically into two types. There's what we call the active surveillance or the passive surveillance. For the active, it involves an ongoing search for cases in the community or health facility. This may involve regular contact with key reporting sources by making telephone calls to healthcare workers at a facility or laboratory, or physically moving to the source and carrying out record review of data. Example includes visiting homes to identify cases of measles or yellow fever during an outbreak. Active case search is critical as part of outbreak response. I'll give us an example. Then for passive surveillance, a system whereby a health institution receives routine reports submitted from health facilities such as hospitals, clinics, public health units, the community or other sources. This is the most common form of surveillance, which involves the surveillance of diseases and other public health events using routine surveillance. Routine health management and information system or other public health information system. So this is what it's about. You look at like you're just doing an ongoing vigilance, and as you collect this data, you analyze, you interpret, you disseminate to relevant people that need to take action. This may be the government, this may be the community or whatever. But for you to collect this data, there are two ways you could do it. You can do it either passively or you can do it actively. For the passive, it's just routine. Like one of the things that is common with the passive is what we call the a common thing that NAFDAC uses is the what we call the yellow form. This one is, you know, it's you are within the health facility and then somebody comes to report to you. Or as people come for immunization, women are told that if their children develop any form of adverse event following immunization, that is AEFIs, they should report back to the facility. So this one, you are seated in the facility and they come to you to report. They come to you to make a report. You understand? So it's or you are in a clinic and a case of measles comes in. It's notifiable. So you pick it and then you get to the DSNO of the local government. Or a case of acute flaccid paralysis comes to you, or yellow fever comes to you. Like we say, there are case definitions. Usually in our consulting rooms in the primary health care centers, we have these case definitions pasted on the wall, such that even the lower cadre staff are able to recognize it and report duly. So that for the routine one, that's actually the passive one. Then for the active surveillance, like the term you actively go out to search for it. So a typical case is in the case of tuberculosis, we have what we call volunteer workers. For some of them, they are NGOs in the bid to stop tuberculosis, use these methods. We have gone from stop tuberculosis now to end the end strategy. So what these people do is that they go actively into the community and make inquiry. Do you have anybody in your household that has been coughing for about 2 weeks? You know, they go out to search. And then when any household signifies that they have somebody like that, they take sample and take it back to the facility. Remember, we said lab is very important in surveillance. On the sample to determine whether this is to confirm if it's actually a case of tuberculosis. I don't know if you can still hear me. I think my audio is shaky. Hello, am I still heard?
Yes.
Okay, all right. So that's just the difference between the active and the passive. Let's not forget a common active surveillance too that was done then was Guinea worm. You know, people looking out for, if you have they go out to the community to look for people who have like thread-like worm or something like that coming out of their skin, especially of the lower extremities, you know, and then report back. Before they were even price tags, you know, to reporting that kind of a case. So that is like you're actively searching for. It's not like you're sitting in your facility and then somebody comes to meet you, you know, with that kind of condition. So that's just the basic difference between the two that we should take note. So these methods I'm talking about could fall in either of those two groups. They could either be active or they could be passive, depending on how you apply it. So the methods of surveillance could be using a focused location for surveillance. Example is a health facility-based surveillance or a community-based surveillance. So it could be either way. When you're talking about a focused location now, either the data we are generating from the hospitals or that from the community. Then it could be a sentinel surveillance. Worthy of note is that we do for antenatal visits, women coming for ANC. We do mostly, we do what we call a sentinel surveillance for them, where these are a group of people that are very unique. One, they are pregnant, and a pregnant woman cannot deny having a sexual contact because that is how she got pregnant. So in this group of people, they are used for sentinel surveillance for HIV/AIDS. Then surveillance conducted at laboratories for detecting events or trends, not necessarily evidence at other sites. So this one would include samples, you know, passing through the laboratories, you know, and then testing on them to determine certain conditions. It could be maybe just taking ecological samples or something. It keeps passing through. There are some studies where they'll keep taking maybe samples of say studying some ecological stuff. It could be insects causing a particular disease, you know, checking their how do I put it now? Their the parasite load in such insect group or something like that, or even to find out whether this insect in this area are infected or not, something like that, you know. Keeping a surveillance on that kind of, some kind of ecological surveillance could be that kind of example, and then they take it to the lab and then check. Then for case-based surveillance, For case-based surveillance is disease-specific surveillance involving activities aimed at targeted health data for specific disease. In this case now, like I talked about measles, or talked about, in fact, a very recent one, we can talk about COVID, we can talk about monkeypox, talk about Marburg, and the rest of them. These are case-based surveillance on a particular or specific disease you are trying to look out for. Even now, you will be looking out for, despite the fact that polio has been eradicated in our region, it doesn't stop you from doing your surveillance. You keep looking out for. You keep looking out for. Actually, a good surveillance system is such that it's, that's very concern for some of us from the low and middle income countries during the case of COVID. If you don't have a surveillance system in place, many events will pass you by, and some of those things could be catastrophic. So that is just that about that. So this is just an example of the yellow form I talked about, which is the National Pharmacovigilance Center kind of form that they use to collect adverse drug reaction. Also, in the case of COVID, there were many, there was also both active and passive surveillance that were being carried out. At times we could just be at the center where the vaccine was being given, and people passing through there they may just report and say, okay, I had this symptom, I had that symptom, and all that after taking the vaccine. Or there was another study we're carrying out where we call these people to find out on various days, for about 3 months or thereabouts, to ask from them, did you have this symptom? Or that symptom and all that. So we actively search for, because it was something very novel, and people wanted to know what were the adverse reaction to the vaccine, and so that was done then. So in that case, it was more like adverse event of special interest that was being done in the case of COVID. Oh, so for monitoring is the performance and analysis of routine measurements aimed at dictating changes in the environment or health status of the population. Thus, we have monitoring of air pollution, water quality, growth, and nutritional status. So, so apart from even monitoring, which may involve, basically, what I would like us to take note is that monitoring is basically an assessment. In the case of monitoring, you don't have to compare it with a standard, or it's not as if there was, will I say, specific objectives from the first place, like you set a target and then you now assess and try to compare it to the target. No, in this case, it's just basically an assessment. So I want to check the air quality. What is the air quality? What I mean is this: for the air quality, it's not as if there are no, we have what would be the normal region, and what if above this you consider to be like as if the air is polluted. Yes, they are standard like that, but then maybe if it's not monitoring, I could set my standard from the beginning and say, okay, even though this is the normal, for me, this is where I want, these are my objectives, to have this air quality in this place, even though I know it's a place that is has the tendency of being polluted, but this is my standard that I want to have, something like that. When we go to evaluation, I'll try to explain it more for us to understand. But what I just want to take is that monitoring is just basically an assessment. It does not compare with a standard, unlike evaluation. But then it might get confusing as we go on, that you find out that a type of ongoing evaluation is also called monitoring. but just leave it as at that, that for monitoring is just basically an assessment. While for evaluation, you have a set objective or set standards with which you are going to compare your assessment. In the case of monitoring, something we do commonly in our health setting is medical audits or something like that that we do, or some of those like patient exit interview we do to assess our quality of care. So as the patient is exiting the facility, you want to know, was this patient satisfied, maybe with the waiting time, with the quality of time that the doctor gave to him or her and all that. So you want to monitor the system to know what is going on within the health facility. So basically, this one is ongoing measurement of performance of a health service or a health professional, or of the extent to which patients comply with or adhere to advice from health professionals. You know, all the while what we've been covering is control of infectious diseases, and that is where the surveillance and the came into play after we discussed various aspects of the control of infectious diseases. But you must remember that in controlling infectious diseases, there's what we call the 4 C's: the cases, the contacts, the carriers, the community, in doing your control. For the cases, for them, you must diagnose, and when diagnosed or picked, if they are notifiable, you should notify. Cases too should be isolated. And then there is if it's an inanimate thing, or you could disinfect for inanimate things like surfaces that is contaminated by cases and all that. And then you treat the cases. So let's say, what I mean is this, like their beddings, doorknobs and all that, where you have cases, you could, let's say in infectious disease like COVID or some other stuff like that, that you have contaminated surfaces, you disinfect. That is for inanimate objects. Then you treat the cases, you follow them up, and when they are fine, or when they are cured completely and they are no longer a threat, you release them. Then for contacts, remember we talked about quarantine. For contacts, you observe them to see whether they develop disease of interest or not, for at the maximum incubation period of the particular disease. Then for carriers, you detect, we have many disease entities. For many disease entities, they have carrier states, and for these carrier states, you need to detect them, because the case of carriers is that they are, how do I put it? They seem to be less worrisome to you because they don't have the symptoms. But where the worry comes is that where they are become very important is the fact that they are able to, when they are able to shed the organism and infect other people. For a case, for somebody who is a case, they come to the hospital, they get treated, or you are even careful around them because you know they are cases. But for carriers, they may be asymptomatic. They are asymptomatic. They may even be healthy people, or they are recovering. Remember we talked about the types of carriers: convalescent, healthy, incubatory. So in that period of incubation, they might not particularly have any symptom, and so people are not even careful around them. Say in the COVID era, when you meet somebody coughing, you take caution, you stay away and all that. But carriers, they are not that way. Though I'm not saying that COVID has carrier states. So then in the case of the community, which is the fourth C, you could carry out epidemiological investigation and contain the event. So it's just a summary in essence of all we've talked about on the control of infectious diseases. The thing about control is that when you're talking about control, you remember the levels of control, and then you try to find out whether there are strategies or programs that is aimed at controlling the disease, basically. So evaluation is very important. If you have a control program, it must be evaluated because you want to know. Okay, take for example, in the case of malaria, we know that it is said that about 4 persons or so die, though this is an old figure, about 4 persons die every minute or thereabout. So if this is my finding, and then I will now set my target, I'm starting my malaria control program. What do I want to achieve at the end of the day? I could say, okay, because program has to be realistic. Since there are 4, I want to say by the end of the year, I want to reduce the number of deaths to 2 persons per minute. So this is a set target. So I institute my control program and all that. At the end of the year, I go back to reassess. And then let's say after reassessing, I find out that, oh, yes, my program has caused a reduction, but what I have is 3 persons per minute. Yes, your program has achieved to some extent. You have some kind of achievement, but it is not your target. So you need to feed back to the system and see, where have I done wrong? Where do I need to make corrections? What do I need to modify? And then reassess it after it runs for a while to see that you hit your target. So, but if we do not evaluate, we may not know whether our program was successful or not. Because we've made some progress, we might just feel like we've done well. So evaluation is very, very important for any public health program. So I'll just run on quickly so that we can cover non-communicable diseases. But if I'm going too fast, you could stop me. So non-communicable diseases, the study is also can be called chronic disease epidemiology. They are beginning to assume increasing importance both in the developed and developing countries. There is an epidemiological transition from communicable diseases such as perinatal and nutritional disorders to predominantly non-communicable diseases in Nigeria. Formally, excuse me, formerly what we dealt with was more of the communicable diseases, infectious diseases causing morbidity and mortality. But now we're beginning to talk about the double barrel of diseases, where you are dealing both with communicable as well dealing with the non-communicable diseases. So, and that is the kind of transition we are beginning to experience as we are getting more developed. So non-communicable diseases are increasingly becoming an important contributor to national disease burden and therefore a major public health concern. So they are usually chronic diseases that are typically non-contagious, non-infectious, and not transferred from person to person. Like we talked about the case of hypertension, diabetes, sickle cell disease, and the rest of them. These are non-contagious, these are non-infectious, and they cannot be transferred from person to person by reason of contacts, because we know that sickle cell actually can be inherited, but you can't contact it from another person. So non-communicable diseases result from genetic or lifestyle factors, which we'll be talking about, the risk factors. They cause death, dysfunction, and impairment in the quality of life. And they also include injuries, such as road traffic accidents and the like, and other injuries. Now we are beginning to talk of suicide and the rest of them. These all form the non-communicable diseases. So they are the leading cause of functionary impairment and death nationwide. So as we talk, I'll show us some data just to signify this and for us to just take note of them. So they accounted for about 33.4 million deaths worldwide, and 72% occurred in developing countries such as Nigeria. They are among the 10 top causes of morbidity and mortality in Nigeria as well as globally. Adults are more affected, except in the case of sickle cell disease. Then imposes heavy economic burden on individual societies and the health system. This goes without saying. Take, for example, for hypertension or diabetes, that we know that they are basically managed and not necessarily cured. These people will keep going for follow-up. They have to pay for their hospital visits. They also have to pay for their drugs, and all that which they would need to be able to manage their condition. So it comes at a cost. And even in terms of how these people will be productive to their society, if not well managed, or if they come down with complications, there are certain things they may not be able to do. And so we lose out on their contribution to the society. And our overburdened, our stretched health system is also faced with the challenge of coping with these people also coming into sick care. So it comes at a cost to everybody. So I have for more recent data, in the year 2019, the top 10 causes of death accounted for, which accounted for 55% of the 55.4 million deaths worldwide. So I'll show us that later. For the top 10 causes of deaths, the majority of them are due to non-communicable diseases. The top 10 global causes of death in order of total number of lives lost are associated with three broad topics, talking about cardiovascular, such as ischemic heart disease, stroke, respiratory, that is COPDs, lower respiratory infections, and neonatal conditions, which include birth asphyxia, birth trauma, neonatal sepsis infection, and preterm birth complications. So I would show us that, and then so that we'll just have a graphical representation of what I'm talking about. So basically, these causes of death, if you are looking at it, they can be majorly grouped into three subheadings. They are either communicable, non-communicable, or injuries. And at the global level, 7 of the top 10 leading causes of death in 2019 were non-communicable diseases. That is looking at the wholesome value now. But when you go down to low and middle income country like us, the picture may be a bit different. These 7 causes accounted for 44% of all deaths, or 80% of the top 10 causes of death. So this tells you how important non-communicable diseases are becoming. However, all non-communicable diseases together, excuse me, accounted for 74% of deaths globally in 2019. So this is a more recent data. Other diseases which were among the top 10 causes of death in the year 2000 are no longer on the list. An example is HIV/AIDS, which used to be one of the top 10 causes of death, and it has now fallen from by 51%, sorry, it has fallen by 51% during the last 20 years and has moved from the 8th position in the top 10 causes of death to the 19th position in the year 2019. While kidney diseases, we know that CKD, everybody is talking about it here and there. So it has risen from the world's 13th leading cause of death to the 10th cause of death. And mortality from CKD has increased, from kidney disease has increased from 813,000 in the year 2000 to 1.3 million in the year 2019. So this is what I was talking about. This is a global picture, just to show us how important non-communicable diseases are becoming. So the top one, we have ischemic heart disease, stroke, COPDs, lower respiratory infection, which is the first communicable disease to make it up here, neonatal conditions, which could be both infectious and majorly non-infectious, but they are also majorly infectious, but they are also non-infectious conditions here. Then cancers are coming in here, then Alzheimer's disease and other dementias, diarrhea disease, diabetes mellitus, then kidney disease, which I said came from number 13th up to number 10. And then HIV is no longer in the picture, which means we are winning on HIV, but more is left to be done. So while some are increasing, others have gotten better in the past 10 years, 20 years, sorry. So we now have cases of ischemic heart disease, stroke, COPD, lung cancers, dementias and Alzheimer's. All those ones are still there on the increase, while others are beginning to, some are dropping, such as diarrhea disease and neonatal conditions, as well as lower respiratory infections, which is basically what we are talking about, that the infectious diseases are beginning to go down and then and taking the back burner, but the non-communicable diseases are becoming at the forefront. So this is for a low income country. We can see that it's more of the infectious diseases that are up there. The top two are communicable diseases. I won't bother us too much on that, just to give us a graphic representation. Then this is for low middle income countries such as Nigeria. We still have ischemic heart disease as the top there, as number one. It's actually increasing. And this is not surprising because I guess we have better diagnosis and all that, so we can detect it better. Then stroke, neonatal conditions, even though it's on the decrease, is an infectious disease, but it's the top three here. It takes the 10th position, the third position here. Then COPD is on the increase. Lower respiratory infection is dropping, but it's on the 5th level here. And diarrhea disease there's been a marked decrease. However, it's still among the top 10. We still have tuberculosis with us, cirrhosis of the liver, diabetes, and for us, injuries made it to the top 10. So this for upper middle income country. So the picture is a bit different. In terms of absolute number, there are cases of ischemic heart diseases and stroke is much more higher here. Then this is for high income country. Their own picture is the infectious diseases are far lower down. In fact, so far here, it's the lower respiratory infection that took the sixth position, but other things like the diarrheal disease and the neonatal conditions did not make it to the top 10 here in the high income countries. So why are the non-communicable diseases gaining greater importance? One, control of communicable disease, which is obvious. So we have decreased incidence of these communicable diseases now. So they are becoming less important, and then communicable diseases are getting, non-communicable diseases are becoming more important. Then urbanization and industrialization. If you picture where we were around, say, 1990 and now, our level of urbanization is increasing. We used to be more rural, but we are becoming more urban, and that comes with its lifestyle changes and the rest of it. So lifestyle and behavior is also very important in many of the non-communicable diseases. Then increased life expectancy. We are having increasing aging population are becoming older. Our life expectancy is increasing. Even in Nigeria, ours has increased. Then modern health services. You know, we have many technologies now, even to better dictate diseases. You know, like say in the case of Marburg now, it's usually thought to be an event that was, will I say, rare or not so common. But with better technology and better testing technology, it was now found that it was actually has been happening all the while from the 90s in certain parts of Africa. So how we can classify these non-communicable diseases into trauma, where we have injuries and accidents, domestic, road traffic accident, industrial, and terrorism. So, and just a quick one here for trauma, it's not surprising. We are beginning to deal with insurgencies and insecurities here and there. And so you can see why injuries is among the top 10 in the low middle income countries. Neoplasms, cancers of the breast, the cervix, liver, prostate, congenital conditions such as cleft lip and palate, heart defect, clubfoot, nutrition, marasmus, kwashiorkor, obesity, and for nutrition, it's as we are becoming more urbanized, we are not just dealing with where we have a severe malnutrition, undernutrition in our rural areas. We're also dealing with overnutrition in our rural areas. We have many obese children running around. Endocrine, thyrotoxicosis, Cushing's syndrome, degenerative conditions such as hypertension, arthritis, coronary heart disease, allergic conditions such as asthma, which also has a lot to do with industrial activities and other lifestyle changes which we have acquired. Then metabolic conditions such as diabetic mellitus, mental conditions such as substance abuse and depression. In fact, it's being said now that mental conditions are now referred to as silent epidemics. Then intoxication such as poisoning and alcoholism. So those are the classifications of the non-communicable diseases. So for the major non-communicable diseases in Nigeria, they include hypertension, coronary heart disease, stroke, diabetes mellitus, sickle cell disease, cancers, G6 PD deficiency, road traffic injuries and violence, asthma, etc. So this is the burden in Nigeria. About 4.3 million Nigerians greater than 15 years are hypertensive. Hypertension is more in urban than rural. Mean total cholesterol is low in general populace. About 1% Nigerians greater than 50 years are diabetic. However, it's a bit higher in the male compared to the female. Then 0.5% of Nigerians greater than 15 years also have sickle cell disease. That is about 1 million of them. This excludes the pediatric population. So, and this is not even a recent data, so we can imagine what the trend is presently. 0.1 million new cases of cancer diagnosed yearly. 6 million Nigerians are asthmatic, mostly children. Greater than 7,000 Nigerians die from road traffic crashes, and 26,000 injuries. Let me not bore too much with that. So generally, non-communicable diseases are permanent. They are caused by non-reversible pathologic alteration. They leave residual disability. Patients require rehabilitation. They require long period of supervision, observation, and care, like we talked about in the case of hypertension and diabetes mellitus. Then they usually affect adults, except for certain disease conditions like we've talked about, sickle cell anemia. So there's also absence of known agents. Like you can't tie them particularly to an organism such as or to chemicals such as silica or asbestosis in some conditions. So what you have for the non-communicable disease is more like what we call the multifactorial cause of disease, where there are so many factors that come into play, both factors in the agent, which is the which could be chemical, factors in the environment, and factors in the susceptible host, which come to play together to, lead to the disease. So it basically means that there's absence of one risk factor. And risk factors that are positively associated with the risk of development of a disease, but are not sufficient to, to cause the disease. So at times, one of these things on its own may not necessarily cause the disease. I wouldn't want to go too much into detail, but there's what we call like their component causes, their necessary causes, and their sufficient causes. So you find that you have different risk factors that come to play. However, if you are talking of, let's say you have risk factors A, B, C that intersect to cause a disease. So if, say, for example, the risk factor A must always be present to cause the disease, must always be present to cause the disease. All those three ABC, they are called component causes. But among the component causes, there's what we call the sufficient cause, and then there's what we call the necessary cause. Some factors are sufficient, while some factors are necessary. For some of the factors, they must always be present for the disease to occur. That's the sufficient cause. While for others, they are necessary. So they are there, but they must not always be there. So A, B, D can cause the disease. A, C, D can cause the disease. And A, like that. What I just mean to say is that you can see that A is always recurring. So it means that A must be there. But the other components, B, C, D, are necessary. And altogether, they make the component cause. Then for they usually have long latent period. That is period between first exposure to suspected factor and eventual development of the disease. Take for example, for say long CA now, this individual may be exposed to smoking, may have some other genetic factors and all that. And most likely, maybe he's not smoking a filtered cigarette, you know. So all these come together and then results in the person maybe coming down with lung cancer, maybe in 30 years time or thereabout. So they usually have a long latency period. So the implication is that they are difficult to link to a factor and disease and difficult to prevent. There's also an indefinite onset. You can't say, okay, this is when exactly this person was exposed to the risk factor that made this person to become hypertensive. You know, there's no clear defined line. Then there's no distinction between disease and no, it's difficult to distinguish between disease and no disease, except, you know, unlike for infectious disease where you say the organism is present, the organism is not present. This is not typically the case in the case of non-communicable diseases. So I don't know whether we should stop here or we should run through the risk factor because we started like 10 minutes late. Hello? Hello?
So we can hear you.
Okay, so I said, do we continue for another 10 minutes?
No problem, doctor.
Okay. So common risk factors in non-communicable diseases include smoking, excessive alcohol consumption, lifestyle issues such as poor diet, lack of exercise, you know, our sedentary lifestyle, all that, even sexual behavior, have many risky lifestyle behavior that contributes to non-communicable diseases. Stress, you know, we are faced with a lot of stress, a lot of issues we are dealing with in this present time. Family history is also a contributing factor. Advancing age, like we say, that life expectancy is increasing. Unhealthy reproductive and sexual behavior, occupational exposure, you know, industries where where workers are exposed to certain chemicals that can be harmful to their health. An example is when we talked about the asbestosis, silica, and the rest of them. Then environmental factors such as pollution, occupational hazard, nuclear weapons. There's a lot of air pollution as a result of industrialization, you know, improper refuse disposal, and the like. Even though these conditions are difficult to control, there are certain aspects of it that can be controlled, and that's where the modifiable risk factors come into play. These ones can be modified. There are certain parts we cannot modify, but some aspects can be modified. And when these modifiable risk factors are controlled, there's a significant improvement in the non-communicable diseases, whether in terms of incidence or even for the individual who would suffer from it. So for the modifiable risk factors, it can be in terms of lifestyle or environment. So we talk of smoking, excessive alcohol consumption, dietary pattern, physical activity, and environment. We talk about exposure to occupational. So other factors could be failure or inability to get preventive health services such as screening, early treatment. So these are things that could come into play when you are talking about non-communicable diseases or stress factors. You know, all these are within our control. Having a better, giving people better access to health, either to screening or to early treatment, is very important in non-communicable diseases. Then stress factors are also things that can be modified. If you're able to reduce or even totally remove the stressor, then you reduce the person's risk of developing the disease or even coming down with complications if the person is having the disease already. Then also sorry, this should be in the case of hepatocellular carcinoma. So I'll just run through this one. Some signals of the chronic diseases. Take for example, any sore throat that does not heal, lump or thickening in the breast or elsewhere, unusual bleeding or discharge, any change in mole or swelling, persistent hoarseness or cough, persistent indigestion or difficulty, change in bowel habits, chronic pain. These are signals that should make one go and check if one has any of the chronic diseases. And the sources of data for these chronic diseases could be hospital-based data, could be ad hoc surveys, you know, national surveys or cancer registry. Okay. Most importantly is the prevention of these non-communicable diseases, which I would like us to quickly run through before we stop. So, like I said, whenever prevention is talked of, you should just look at it in these 4 possible ways, even though I say that there could be quaternary. But think of primordial, primary, secondary, tertiary. Then you think of the possible things that could fit into it. For the primordial, you'll be talking about legislation, policy formulation, and the likes. Like I said, you don't even want anything you do that will prevent the risk factor from even occurring in the population in the first place. So you'll be talking about anti-smoking laws, taxation on cigarette companies, taxation on alcohol companies, drug abuse laws, and the other legislations. For primary is health protection, health promotion and specific protection. So for the health promotion, you want to raise awareness. You want people not to live such lifestyles that would expose them to developing, even though the risk factor is existing now, you don't want them to develop the disease. So for a person who has a family history, you tell the person to avoid sedentary lifestyle, modify diet early and all that. So that has to do with physical activity, relaxation, rest, good nutrition, emotional stability, avoidance of stress, health education, avoidance of exposure to harmful substances. So just think health promotion, specific protection whenever you are thinking of primary. Then when you are talking of secondary, in this case now, not only does this individual have the risk factor, but the individual has now developed the disease. Most likely maybe because the person did not do the primary prevention. So for this individual, you would want to screen and treat. So it is early diagnosis and prompt treatment. That is what encompasses secondary prevention. So we talk of screening. If you are talking of early diagnosis now, you want to screen for these conditions. Like we said, they have long latency period. So when you're able to screen, you now get a lead time on the disease before symptoms start appearing, and that gives you better prognosis. Also, case finding. Say if an individual has a certain condition, let's say in the case of sickle cell disease now, a child comes to your clinic with sickle cell and you're able to diagnose him or her of sickle cell anemia. You want to do case finding and find out, okay, what about the siblings? What are their genotypes? So it gets you to look out for more. Then prompt treatment. You institute your treatment early. Then for tertiary is, like I said, basically is limit disability and rehabilitation. And this could come in different spectrum, whether medical, social, vocational, or economic. For the medical, certain, let's say in hypertension now, to prevent them from having cardiac. 1989 where it is necessary, you provide program. (1989) by the Federal Ministry of Health. It's an arrowhead for response for non-communicable
Please, we could not
diseases.
hear you.
Okay,
The line
sorry
was
about
breaking.
that. Okay, so sorry about that. Okay, at this stage or before this?
Before now, but at this
No,
stage,
please, is this a continuation of the levels of prevention?
No, for the levels of prevention, it was
Tertiary.
like a general, yes, like a general. If I get what you're asking, talking about levels of prevention,
It ended here. It ended
yes.
here. Oh, okay.
No, for levels of prevention, we talked about it generally to know what it entails, like what is the levels of prevention. But then you're now going to apply this knowledge when you're talking about control or prevention of diseases. So earlier on, we had applied it to the communicable diseases. So now, please excuse me. Now we are applying it to non-communicable diseases. So for the non-communicable, you now look at it. What are the primordial, what are the primary, what are the secondary measures, what are the tertiary measures? So I've applied the levels of prevention in non-communicable diseases here. I don't know if that is clear.
Okay, for example, this should be sufficient in case one is asked to do for levels of prevention for non-communicable disease. This should be.
Yeah, if you should suffice. Prevention of non-communicable diseases, yes, you look at it in this light. Okay. It can be primordial, it can be primary, it can be secondary or tertiary. But if you are asked for level of prevention generally, you just say these are the levels of prevention: primordial, primary, secondary, tertiary. But then you just state what it is. For the primordial, you don't want the risk factors to occur. It has to do with policies, legislation, and all that. For the primary, the risk factor is there. You don't want the disease to develop. So you talk of health promotion and specific protection, such as factors like immunization and the rest of them. Then for secondary, it's early diagnosis and prompt treatment. So you talk of strategies such as screening, case finding, prompt treatment. Then for tertiary, it's disability limitation and rehabilitation. And the rehabilitation can be in different form, medical, social, vocational, economic. So if you now use this knowledge and apply it to non-communicable, so what are the things I can do to prevent the risk factors of non-communicable diseases from occurring in the first place? So we talk of anti-smoking law, alcohol, drug abuse laws, legislation, and laws and legislation. Then in the primary, I talked about in health promotion and specific protection, you begin to raise awareness, raising awareness, asking people to modification of their lifestyles in terms of physical activity, relaxation, rest, nutrition, and the rest of them. And before I forget here, it may not, at the first look, you may think that specific protection may not apply to non-communicable diseases. But remember, we talked about recent knowledge where we are now beginning to talk about viral carcinogenesis, such as the case of HPV, hepatitis, and all that. So you cannot begin to talk about even specific protection in the case of non-communicable diseases. So in the case where you give immunization against HPV, immunization against hepatitis B virus, like that. So that is specific protection in that light. That is primary. Then secondary, you screen for the disease. You also do case finding where it applies and you treat appropriately. Then disability, limitation, and rehabilitation in all these spheres like I talked about. So I think it would be good if we stop here.
Okay, thank you very much, Shiva. We so much appreciate
Thank
you.
you so much, ma'am.
Thank you.
Thank you, Doctor.
Thank you very much.
If there's any question, we can ask. If there's any question, please kindly ask.
Hello, doctor.
Yes, I can hear you. Good evening.
Yes, good evening. Please, can you repeat what the yellow form is? Is it active or passive surveillance?
Okay, the yellow form is actually passive. It's part of the routine things we do in the hospital. Like if people have adverse drug reaction and then maybe they report to the facility, or even if it's an AEFI, they report, then you record, and then it goes to NAFDAC. So that is passive. That is part of the routine. It's passive. Other things we do that is also passive, even though we didn't really discuss IDSR in detail, but we have some of those forms that we use that, at the end of the week, at the end of the month, there are certain reports that facilities send to the local government, ideally, that should be done. Apart from the notifiable diseases, that even if you pick one or few cases, you notify directly. But generally, there's a baseline where you routinely send data to the local governments. So just see it as anything those ones that are done routinely, any surveillances that are done routinely, that is part of the everyday running of the facility, is routine. Is passive. But when there's an active search, then that becomes the active surveillance. I don't know if I was able to answer your question.
Yes, you did. Thank you so much, doctor.
You're welcome.
Thanks, Dr. Tubi. We appreciate you for the lecture series. Once more, we say thank you very, very much.
You're welcome, sir. Thank you. Thank you for listening.
Thank you so much, doctor.
Okay. Shiva Tubi, I don't know if you could end the recording now.
Okay, I'll do that now.
Okay, just end the recording.